So we're going to do the same thing now. We talked about the frontal plane alignment. We learned the language that we're using in the frontal plane for the angles. Now we're going to do the same thing, but on the sagittal plane analysis. And we also, in the sagittal plane, need to understand the concept of the soft tissue deformity. So we're going to do the map part of the map of the ABCs on the sagittal plane. So it's the same concept when you're looking at the lateral view of a leg. You can draw a line from the center of the femoral head to the center of the ankle, and that's going to be your sagittal plane mechanical axis. But you also have to draw the hinge point of the knee, because this is an important marker for how things are going to go for the patient. So, the x-rays you need to have are in maximum extension. This is very important to be able to figure out the bony deformity and the soft tissue deformity. So the straight line that connects the center of the hip to the center of the ankle should pass in front of the hinge point of the knee. Now, how do we define the hinge point of the knee? There's two ways. The first way is the intersection of the physeal scar and the posterior cortex of the femur. And where those two lines intersect is the hinge point of the knee. So if you look at it on an x-ray, you have the physeal scar and the posterior line of the cortex of the femur. The second way to do it is Blumensatz's line and the posterior femoral cortex. So this is what it looks like on an x-ray. And how do you pick which way to use? Typically, when you have an open physis or it was closed recently and you still see the physeal scar, you use the physeal scar. If you can't, you use Blumensatz's line. Now, in most people, this mechanical axis line should fall anterior to the hinge point of the knee within the confines of the distal femur. That's normal alignment in the sagittal plane. And it's very important that this line passes in front of the hinge point of the knee, because for you to be able to stand for a long period of time with your knees locked in extension, you have to pass in front of the hinge point of the knee. Otherwise, you're constantly using your quads to support yourself. And then you tire very fast. This is how soldiers, you would know better than me, stand at attention for hours without activating their quadriceps. Okay, so very, very important. Now, when this line passes posterior to the hinge point of the knee, you have a flexion deformity. When it passes anterior, like I showed you in that case, you have a hyperextension deformity. And the way we know that the mechanical axis is deviated is if it passes outside the normal zone, which is the confines of the femur. The goal of our surgery is for the mechanical axis to pass within this normal zone, anterior to the hinge point of the knee. So that's the mechanical axis and mechanical axis deviation. Same idea, sagittal plane. Now we're going to measure or analyze the joint angles. So the joint angles, same thing, we know the definition. We're going to look at how they get measured on the sagittal plane. So it's the intersection between the joint line and the mechanical axis line of either the femur or the tibia. And the way we do the joint line in the distal femur is we draw a line anterior to posterior at the aspect of the physeal scar. So you're going to look at the condyles and you're going to draw that line. Now this can be funny on an x-ray because if you don't have the condyles perfectly superimposed, you have to cheat a little, make it up a little. You're sort of guessing, unfortunately. That's why it's nice to have a very good lateral. And for the tibia, it's going to be the anterior-posterior aspect of the tibial plateau. So that's what it looks like on an x-ray. And distal tibia, it's going to be the beaks, the posterior and anterior beaks, where you draw the line. So those are the joint lines. Now, how do we draw the modified femoral mechanical axis line of the femur? How do we just separate it for the femur? So we draw a point at the center of the femoral head, and now we find a point 1/3 of the total distance of the joint line from the anterior cortex. So this is the 1/3 from the anterior cortex. Again, you divide the distal femur on the joint line in 3 parts. And that's your mechanical axis line for the femur in the sagittal plane. Sorry. For the tibia, it's going to be the 1/5 mark from the anterior cortex to the center of the ankle. And that's how you draw your mechanical axis or the modified mechanical axis line for the tibia. So, these are going to give us the angles that we're looking for to know what is normal. So, these lines are called the posterior distal femoral angle, the posterior proximal tibial angle, and the anterior distal tibial angle. And remember, why did it go anterior in the distal tibia? Because we do the angles that are less than 90. Okay? And the nomenclature is the same as in the frontal plane. Posterior distal femoral angle, posterior proximal tibial angle, and anterior distal tibial angle. The easiest way to remember this, in my opinion, is approximately 81 degrees. Sometimes the PDFA is 83. It can go anywhere from 79 to 87. The PPTA, 81 degrees, and the ADTA, 80 degrees. So in my mind, I always say 81 degrees plus or minus, and we're in the good ballpark. So, if your posterior distal femoral angle is smaller than it should be, you get a flexion deformity. If the posterior distal femoral angle is bigger, bigger than it should be, can I go backwards? If it's bigger than it should be, you get an hyperextension deformity. For the tibia, if the posterior proximal tibial angle is smaller than it should be, again, you get a flexion deformity. And if it's bigger than it should be, you get an extension deformity. And for the distal tibia, same thing. If it's smaller than it should be, you get a flexion. If it's bigger than it should be, you're going to get an extension deformity. Okay? So, increasing knee angles generate recurvatum deformity. The PDFA, the PPTA, and the ADTA are the three angles to remember in the sagittal plane. So, not too hard. Now we have to talk about the other two angles, the sagittal mechanical axis angle and the sagittal joint lying angle. So the SMAA, the sagittal mechanical axis angle, is the angle that forms with the intersection of the mechanical axis lines that we just learned to draw for the femur and the tibia. So you're going to draw your line from the center of the femoral head to the 1/3 mark for the femur, and the line from the 1/5 mark from the tibia to the center of the ankle. And those lines, where they intersect, should be 0. They should be collinear. That's a normal mechanical axis. But when you have increasing knee angles and you have a recurvatum deformity, your SMAA is going to be positive at 19 degrees. You have a hyperextension deformity. And if you have a flexion deformity, we're going to say it's negative 19 degrees because it's inflection. Okay, so when those two lines aren't collinear, you're going to determine how much flexion or extension you have of the leg by doing the SMAA. But how do we know that it's coming from the bone or if it's coming from the soft tissues? We're also going to have to measure the sagittal joint line angle, similar to what we did on the frontal plane. So this angle is formed by the intersection of the joint lines at the knee, same as we did on the GLCA on the frontal plane. Now the difference here is that the normal angle is 16 degrees. Okay? So that's considered normal. When you have a flexion contracture, it's going to be negative. When you're in flexion, remember, it's always negative. So you have a negative value for this. And in your hyperextension deformity, you're going to have a positive angle, which means it's going to be bigger than 16 degrees. So what did we learn? The mechanical axis in the sagittal plane is a line drawn from the center of the femoral head to the center of the ankle. It has to pass anterior to the hinge point of the knee, but in the confines of the distal femur. We want to measure our angles, the posterior distal femoral angle, the posterior proximal tibial angle, and the anterior distal tibial angle, all approximately 81 degrees. We want to look at the SMAA, which is the mechanical axis of the femur, mechanical axis of the tibia. They should be the same line. If they're not, you have a flexion or extension deformity. And the SJLA is going to tell us about the soft tissue component coming from the joint lines at the distal femur and the proximal tibia. Thank you.